Good evening. This is Lianne Gensler from UCSF in San Francisco reporting for Room Now for ACR Convergence 2022, day 2 of the conference. And I'm going to be reporting on spondyloarthritis and the best things I've seen today at the meeting. So my theme for today includes novel therapies and then diagnostic dilemmas and thinking about depression as a comorbidity in our patients. So in the treatment abstracts today, there were 3 novel mechanisms that were presented in different phases of study that are worth knowing about because these are going to eventually probably come to fruition as therapeutic options for our patients with psoriatic arthritis. And so that included abstract 1597 presented by Frank Behrens on a novel mechanism of izokibep, which is a fusion protein of an IL-17A inhibitor that is quite small and is able to get to places that perhaps bigger molecules are not. And this was a 16-week randomized controlled, placebo-controlled phase 2 trial that was positive in psoriatic arthritis. In addition, abstract 1598, which was an abstract presented by Philip Meese on a TYK2 inhibitor, deucravacitinib, in psoriatic arthritis, presented 52-week results from a randomized phase 2 trial with longer-term efficacy and safety. And then finally, abstract 1599 is an abstract with bimekizumab presented by Joe Marola, looking at patients with active psoriatic arthritis who had an inadequate response to TNF inhibition. And this was the 16-week efficacy and safety data from a phase 3 trial. So all nice data, either phase 2 or phase 3, some initial primary endpoints and some longer-term efficacy and safety data, but looking forward seeing novel mechanisms that we will hopefully have to use for our patients with spondyloarthritis and in particular psoriatic arthritis here. Moving on to the next abstract session today, there were a couple of abstracts that are worth mentioning, and that included abstract 1613 that was presented by Will Tillett, who looked at diagnostic delay in patients with psoriatic arthritis and actually compared it to patients with rheumatoid arthritis, and noted that in this early arthritis audit, patients with psoriatic arthritis had a longer delay to diagnosis, including a longer delay to referral to a rheumatologist. And then even when they were seen by a rheumatologist and diagnosed, they actually had a longer delay to treatment with a DMARD, despite being willing to, escalate treatment. And using a DAS28, which is not the greatest measure for psoriatic arthritis because it really excludes the lower extremity, including specifically the feet. But these patients had a higher DAS, actually, and a higher DAS on follow-up than the patients with rheumatoid arthritis, and yet we're still not getting treated the same way. So really something for us to think about, both in terms of diagnostic delay, but then also are we treating our patients with psoriatic arthritis differently? Another study looked at comorbidities in ankylosing spondylitis. This is abstract 1609 that was presented by Paras Karmacharya using the SOAS cohort. And so Dr. Karmacharya looked at comorbidities in ankylosing spondylitis and how they associated with both disease activity and function over time. And what he noted was after doing a cluster analysis, there was a particular cluster that really did not do well over time, and that was a cluster of depression patients. And most of these patients, 96%, had depression, and they had worse disease activity and function over time. So really an important comorbidity for us to understand and assess in our patients with axial spondyloarthritis because it impacts the way that they may do over time. And we really need to think holistically about these patients. And the final abstract I wanted to mention was abstract 1614, which was presented by Dennis Pudabny. And this was using the PROOF study, which was a multi-country prospective observational study of patients with axial spondyloarthritis. And he looked at patients with axial spondyloarthritis and stratified by radiographic and non-radiographic disease to see if gender was impacted outcomes, and in particular, inactive disease in patients with axial spondyloarthritis. And very interestingly found that in patients with radiographic disease or ankylosing spondylitis, there was no difference in the probability of reaching an inactive disease state, whether you were a man or a woman. However, in the non-radiographic group, women did not achieve inactive disease to the same degree. And so I think the question that came out of this, and a very rich discussion at the end of the abstract, is why? And one of the big concerns is that women with non-radiographic disease may be misclassified as having axial spondyloarthritis and perhaps actually do not have the right diagnosis. So we really need to think about this because there already exists genetic data to suggest that men with non-radiographic axial spondyloarthritis look like ankylosing spondylitis, but women with non-radiographic axial spondyloarthritis do not have the same genetic risk. And that is a problem in that it brings up the question of whether we have a group of patients that may look like axial spondyloarthritis, but actually do not have the disease. And so something for us to think about moving forward as we both diagnose and treat patients with axial and peripheral spondyloarthritis. This is Lianne Gensler presenting for Room Now, day 2 of the conference.